My name is David, 39, from Manchester in the UK. My daughter Isla had a very aggressive form of long QT type 3. Isla underwent nearly every procedure possible for long QT treatment and was given the highest doses of all currently available medications. Isla's diagnosis shortly after birth led to her being treated with extremely high doses of propranolol and mexiletine. Throughout her short life, Isla also took high doses of a beta blocker nadolol alongside magnesium and flecainide. She had a pacemaker and later an ICD, followed by a left cardiac sympathetic denervation, and after further events, the right side was also done. It is impossible to say how effective the sympathectomy was, as she still did have further cardiac events and shocks from her ICD. In 2020, Isla was placed on the non-urgent heart transplant list, as despite all efforts and medications, doctors could not control her arrhythmia. On day 2 of life, Isla received a paediatric pacemaker to prevent her heart rate dropping too low when she started on beta blockers. At age 3, following a cardiac arrest at home, requiring CPR, Isla's device was upgraded to a dual-chamber ICD. She needed pacing at 120 beats per minute, which was considered the top range for a child of her age and weight, and she needed that rate 24/7. After 6 years, scans show that this was very detrimental to her heart muscle. Doctors were unable to reduce her pacing rate without the ectopic burden increasing, and despite optimizing the levels of mexiletine, flecainide and propranolol, Isla was unable to manage even a token reduction of 10 beats per minute without any breakthroughs of arrhythmia. Isla's electrophysiologist was insistent that Isla's mental capacity was severely impaired by the high levels of sodium channel blockers in her system. She was non-verbal and displayed many autistic traits, but could communicate more effectively when she was receiving lower doses of mexiletine. However, her rhythm became very unstable if the dose was too low. We know from the seizures that she had that mexiletine affected her neurologically. Some days, especially early on, were completely lost to seizure activity. At one point, Isla was receiving 40 mg per kilo of mexiletine to prevent arrhythmia. That is 8 times the recommended dose. Although doctors managed to reduce this down to 15 mg per kilo with the addition of flecainide, we were never able to give Isla weight-appropriate doses of either drug, meaning that the only option was to flood her system with sodium channel blockers. This was the hard choice we faced: seizures or cardiac arrest. One of the other problems we've encountered with mexiletine especially is that patients were encouraged to take the drug after a meal to minimise side effects. For a baby, the main source of calories is milk. While it was common knowledge that flecainide is affected by dairy, it was not common knowledge that mexiletine was, and the absorption was impeded by milk. As she got older and her milk intake reduced, she started having tonic-clonic seizures. Another big side effect Isla had from mexiletine was stomach cramps and pains. It is believed that some of her seizures were due to the intense pain she felt. Isla took propranolol 4 times a day, and this made her very drowsy in the daytime while hampering her ability to sleep at night. It is now even disputed as to whether beta blockers are an effective therapy for long QT type 3. She needed medication 7 times a day, including 10 p.m, midnight and 6 a.m. That drug regime was exhausting as a parent, and while Isla would take medication in her sleep, having mexiletine on an empty stomach would often have a knock-on effect to Isla's mood in the morning. It is also not ideal, as it's obviously a choking hazard even when being administered as a liquid suspension, and it is not something which could have carried on indefinitely as she progressed to tablets. Overall, there is a great misconception when it comes to beta blockers and long QT syndrome, and although the message is you have to simply trust that they will keep you safe, they are not a cure for long QT. Even though Isla was on a variety of medications, she required 19 life-saving shocks and CPR 3 times. None of the drugs Isla took were created for long QT syndrome. Mexiletine is not a cardiac exclusive drug, and although it helped reduce her QT interval by blocking the sodium channels in her heart, it also blocked them in her brain. Some of the things that Isla had to go through and we had to endure as a family, I wouldn't wish upon anybody. Sadly, Isla passed away in October 22, aged 6. The cause of death was determined as complications due to SEN5A mutation. The lack of appropriate medications and therapies for long QT syndrome, especially for young children, is in my opinion one of the biggest gaps in modern medicine.